welcome everyone to tonight's webinar, which is the second part of a two-part series focusing on dementia for nurses working in primary care. My name is Melissa and I'm the ACT Health Pathways Project Officer based at Capital Health Network, and I'll be introducing our speakers this evening. This event is a collaboration between COORDINARE and Capital Health Network, who run the ACT and Southern New South Wales Health Pathways Program, as well as the Illawarra Shoalhaven Health Pathways Program and Dementia Training Australia. I would like to start by acknowledging the traditional custodians of the many different lands upon which we are all joining from tonight. I myself am currently on the Ngunnawal land. I would like to pay my respects to elders past, present and emerging, and acknowledge any Aboriginal and Torres Strait Islander people joining us this evening. Before we begin, just a couple of housekeeping things. Please ensure that you have your full name in your Zoom profile so that your name can be recorded for CPD reporting. The session tonight will be recorded. Any questions, please use the Q&A function. After tonight's event, you will receive an online evaluation to complete. Please take the time to fill this in, as we are keen to know and understand how you find the events and what your future learning needs might be. You will receive a certificate of attendance after you complete the evaluation. Before we start, just a quick reminder about Health Pathways. Health Pathways is evidence-informed, peer-reviewed and localised information, which is designed to be used at the point of care by GPs, nurses and other health professionals. Pathways are written and maintained by a team that includes local GPs, and we work closely with subject matter experts to ensure pathways are relevant to the health environments across our regions. Across both Health Pathways sites, there are multiple dementia-related pathways with localised referral information for our regions, and we encourage you to take a look. If you have any feedback about our pathways, please use the feedback button. It's on the bottom of every page, and our team will follow up with you. I have put up the login details for both the Health Pathways programs. For those of you who are not regular users, please contact your PHNs if you want more information or check the PHN websites. Okay, so tonight we are very pleased to welcome two highly experienced educators from Dementia Training Australia. First, we have Professor Dimity Pond, who is a clinical professor with the Wicking Dementia Research and Education Centre at the University of Tasmania. Dimity conducts research in the area of mental health and particularly dementia, focusing mainly on GP identification and management. Dimity has secured over $30 million in research funds and has published over 150 papers in peer-reviewed journals. Dimity also works in clinical practice in Baroa, on the outskirts of Sydney. Caroline Gibson is an early career clinician researcher and a national expert on the role of practice nurses in dementia care. She is completing her PhD at the University of Newcastle on this topic. She has experience as a general practice nurse, district nurse, and complex care coordinator in a community. And I'll now hand over to our speakers.
Thank you. I'll just place current share. Just got to get back onto the screen. So hopefully everyone can see that. So thank you for those who have come back tonight. Really appreciate it, and anyone new with us. So I'm speaking today, I'm on Wadawurrung land, so I'm in Ballarat in Central Victoria. And tonight we're doing part 2 of our session on the approach to assessment and care for people living with dementia. And tonight we're, let's see, why is it not going? There we go. So last week we looked at more about what is dementia and sort of the role of primary care and why it matters that we are more aware of it and know what to do. And tonight we're going to focus more on the role of the primary care nurse within a team-based approach, so working with the doctor, allied health and our other resources, and how as a team we can look at, we'll look at a case study or a couple of case studies depending on time, and how we might approach it, how we might approach a care in the context of cognitive impairment and include others in the team. So just a quick recap of our last session. We talked about how dementia is common, how it's caused by damage to the brain's neurons so they can't communicate, and that how dementia presents depending on which parts of the brain regions are affected. But eventually, of course, as dementia progresses, all parts of the brain are affected. how it's a significant cause of death and disability in our communities, internationally and nationally, and how by understanding dementia, so by attending training such as this, and acting early, it's really beneficial to your patients, because the sooner we recognise something's wrong and start doing something about it and introducing appropriate supports and interventions, then we can support our patients to live the lives that they want to live for many years after their diagnosis. And so it can really help us support a positive approach to care. And one of the reasons we have to really get to grips with dementia and how we can support people is that health policy everywhere is shifting dementia diagnosis and management from secondary to primary care, which I argue is where it belongs, because we do look after people over their whole life. Oh, that's all I have for session one recap. So starting with the nurses, so what is our role in primary care? And from talking with nurses and working with nurses, come up with a few roles, and one of them is health promotion, so brain health promotion. And that's something we already do with a whole lot of things. So we're going to have a look at that first. Then we're going to move on to how do we recognise a change in cognition, and then looking at how cognition impacts on function. And through understanding that, then we can start coming up with some ideas of how to best support the person live independently and have the best quality of life that they can. So to start with brain health promotion, I'm going to get Dimity to go through with us first about, Dimity, perhaps you could, tell us something about the 14 risk factors.
Okay, so they've now worked out that there's at least there's 14 different risk factors for dementia. And the beauty of identifying risk factors is that some of them are modifiable, and we may be able to reduce people's possibility of getting dementia. And a lot of us don't realise that. I know someone came through our practice a few years ago and talked to our practice nurses about this, because it's a great opportunity for nurses to discuss, and the GPs as well. And neither the nurses nor the GPs in our practice were familiar with this information. So, I'll just run through them really quickly. So if you have a poor education in early life, you're more likely to get dementia. So the quality of the education contributes about 5% to your chance of getting dementia. And so that is a really great reason for encouraging people to ensure that their kids go to preschool, school, and sort of have a positive attitude towards learning. So that's something that we can actually do. We can't actually go back, of course, once someone's 75 years old and give them a good education as a child, but we can certainly encourage our patients with young children to ensure their education's good. Hearing impairment is a relatively new one. People with hearing impairment are more likely to get dementia. So you might think, oh, they just can't hear what they've been asked, and it shows up as dementia, but it's not that. It's over a period of 9 years, they followed people with hearing impairment who were cognitively fine, and found that those with hearing impairment 9 years later were more likely to get dementia than those without hearing impairment, who were matched on other aspects of their age and so on. So we're not yet sure if fixing that would help. And Annalise, I recognise you from last time, and nice to hear from you. And yes, they say, Annalise has asked, why is that? And the theory is that our ears use quite a lot. We use quite a lot of our brain processing sounds. So it keeps our brain active. And if you're not processing sounds because you can't hear them, then those bits of the brain pathways tend to deteriorate because they're not being used. And that flows on to causing cognitive impairment. So the other things there, a number of the other things there, thanks Annalise, are related to the same things that we worry about with heart attacks and strokes. So high cholesterol may give you dementia. It may give you a heart attack. It may give you a stroke. It's a very good reason, though, for encouraging people to get their cholesterol down and not eat too much in the way of fatty food. Physical inactivity. I'll skip a couple, come back to them. Physical inactivity, which we know is not good. We need to keep ourselves active. I tell all my oldies to make sure they go out in the garden and pull up some weeds and stuff. And we know that that contributes to heart attacks and strokes and also dementia. Diabetes contributes to dementia as well as heart attacks and strokes. Smoking contributes to dementia as well as heart attacks and strokes. High blood pressure, the same. Obesity, the same. Excessive alcohol, the same. So these things, we're very familiar with advising people about them. But if I mention to people that they're less likely to get Alzheimer's disease if they fix that problem, they go, really? I didn't know that. Oh, I might have a bit of a better effort at, going for a walk every day. Then there's other things there. Traumatic brain injury, you'd understand, might cause dementia later on. And we hear about the football players and the boxers who get dementia. Depression, it sometimes looks like dementia, but it's also a risk factor for dementia. Like hearing, uncorrected visual impairment is a risk factor, probably for the same reason. And social isolation is a risk factor, perhaps linked to depression. And thanks, Lana, I'll come back to family history in a tick. And air pollution. And whenever I mention air pollution, people say, oh, I was in the bushfires in 2019 and am I going to get dementia? And no one knows what the dose is of air pollution to give you dementia, but we do know that people exposed for long periods to high air pollution are likely to get dementia. And so family history, there are some families that have strong dementia family histories and have a particularly bad gene, but in general, there's just a small chance of getting dementia if you've got a family history of it, and it is worth asking about. So, okay, I'll hand back to Caroline.
Yeah, I wonder sometimes the family history, people always ask me that, oh, grandma had it, my aunt in nursing home with it, and dad and all that. Mm. And I sometimes wonder if it's like, some families have a weakness of heart disease, or some families are susceptible to mental health issues. And I sometimes wonder if it's sort of like your family weak spot.
Yes, I think that might be
like
true.
You're saying, as far as the genetics of it, it's quite low, I think, having that particular genetic makeup. But there's most probably something around that being your weak spot, I think.
And there is a gene called an ApoE4 gene you can be tested for, and that will combine very badly with all the other risk factors. So if you drink alcohol and have the ApoE4 gene, that multiplies your risk of getting dementia. So, but we don't routinely test for genes. It's not worth it. It's not a definite that you'll get dementia with those genes.
And then you got all the ethical complications with it, with health insurance companies having the genetic results nowadays. And imagine you wouldn't know if it was real or not, and you have that hanging over your head for
that's right,
a long time till you're older. Thing I think really interesting about this is I'm really blown away hearing impairment's 7%, yet smoking's 2%.
Yeah,
I find those things extraordinary, and social isolation being 5%.
Yeah, it's huge.
They're things you don't really think about. And the high cholesterol, so that was a new one, I think, from earlier this year. And that was what, LDL above 3.
Yes, that's right. It's the bad cholesterol, the LDL. Yes.
So this came from the Lancet Commission, and if you can read the sort of grey writing underneath. So this is from the UK. This data of so there's about 1 million people in the UK with dementia, and all these risk factors together contribute to 45% of dementia cases. So if you had everyone. So in the UK, a 1% reduction, so thinking not 45, 1% would mean 10,000 people potentially are avoiding getting dementia. So I tried to work out with the Australian figures. We've got about 421,000 people living with dementia. So a 1% reduction for us would be just over 4,000 people. It doesn't sound like much, but it would matter to that 4,000 people and their friends and family and communities, I'm sure. And then if we had a 10% reduction, then we're looking at 40,000 people. So that's just a fraction of the potential, which is why I think brain health promotion is so important. And the other thing, when you look at how this is spread, it is actually over an early life, midlife, later life trajectory. It's really important to remember that we can make a difference midlife. And we're talking, you know, your 40s, 50s, 60s. And I think they were saying high cholesterol and getting all these, and obesity and alcohol and all that in your 40s is really when you're starting to get into trouble for dementia later in life, which is kind of a horrifying thought when we only learn these things when we're older. But yeah, so I think it's worth remembering, and that could actually be quite a good use for your 45 to 49 health assessment, which at the moment aren't used particularly well. But that could be a way that you can, you know, use what we've got as our funding system, which is fairly limited, but it could be an opportunity to start looking at heart health and brain health and that sort of thing with people. So I've just got here, it's sort of the flip side of the risk factors. So what you can use in your health promotion is basically, like Dimity was saying, heart health. So, you know, your Mediterranean diet, being physically active, good night's sleep, avoiding drugs, alcohol, etc. Managing depression. And like we said, the optimizing hearing and vision is really significant. And I think it is about sensory, because it does use up a huge proportion of our brain circuitry. And staying social, I think, is so important. And again, I'm always surprised when I think about that. They say that social isolation and a lack of social connections has an impact on shortening your life, the same as if you smoked 15 cigarettes a day, which is quite a lot. And you think we really educate people about the risks of smoking. And social connections is trickier though, but we can, as we talk about, do something, hopefully. And protecting your head and avoiding injury, like Dimity was saying with sports people. I think about that one too, because, and I think it's good that we're encouraging young women into sport and that, but now so many of them are taking up more of those high impact sports like rugby and the AFL. And it's just so important that when at school and that, they are protecting their heads. And of course, young men as well, because it is a significant cause. So I don't know, Dimity, if you wanted to have a chat about these two tools that people may be able to incorporate into their health conversations.
So you can actually look up this COGD risk, and you can do it for yourself. I have done it for myself.
I've done it myself too.
It does, and it not only tells you what your risk is, it asks you about all those risk factors, what your diet is and so on, and how much exercise and so on, what your blood pressure is. And then it gives you recommendations at the end, at least the version I used did, and that was quite useful. So you can recommend that to people who are interested, and they can use that to sort of...
It's validated and perfectly legit to use, free and all that, but you do have to register, so you get it sent to you.
Yeah.
But I've never been sent
Australian
from them. It's from a research project. Yeah.
And Brain Track is Dementia Australia encourages us to look at that, and that's a way of exercising your brain. And I have got it downloaded on my phone, and I started using it, but I haven't gone through a whole one. It gives you a
daily challenges and that on it, doesn't it? I read about it.
Yeah. And what would you pack for a trip to Portugal and stuff like that, you know? Yeah.
So it's a more functional problem. And I think both of them, one of the things they talk about is that you can print off a report sort of thing, which you could get people to bring in with them to their next care plan or health assessment if there was things on there they'd like to discuss, or similar to, I think, the heart assessments you can get out there. I can't remember what they're called now, but there's the heart
health check
ones. Yeah, heart health checks, and have some assessments you can do. It's similar to that. And it doesn't take 20 minutes, so it'll be pretty slow. Okay, so there's a real opportunity there. I think first off, for brain health promotion, we could make a huge difference, even if that's all we did, to start off with our dementia work, is do that. But now what's important too is that if we're going to do something about possible cognitive changes, we need to be able to recognise them. So what I've got here first is a short, it's about just over 3 minutes, a little animation on Nurse Sarah working with Mr. Bird, who's coming to her clinic. And if you just, while you're watching it, have a think about what sort of things Sarah noticed, and then what were her first steps, and what do you think of those? And is this something you would resonates with you for your practice? So for long as it all goes well. Here we go.
I'm a general practice nurse, so you know I'm pretty busy, multitasking, helping, caring, counselling, answering questions, mediating, scheduling, listening, translating, assessing, assisting, observing, educating, dozens of patients each and every day. Nice to see you again, Mr. Bird. Let me take you through and we can see how that wound is healing.
Hello, dear. Nice to meet you. What's your name?
It's Sarah, Mr. Bird. I'm the nurse. How's that wound coming along? I'm in a unique position to see the changes in patients. To ask questions, I can notice early cues that may indicate dementia.
Was I supposed to bring my medication?
No, Mr. Bird, we're looking at your wound on your cheek today.
That's right.
Mr. Bird, remember we spoke about keeping your wound covered and dry?
Of course.
What I see, what I notice, what I do can make a real difference. You seem a little distracted today. Do you feel your memory and thinking has changed?
I do feel a little more forgetful. It is just old age.
I think we'll mention it to your doctor. Is that okay? Doctor, Mr. Bird appears to be having trouble managing his wound. I think a referral to district nursing would be useful. He also feels he's been getting more forgetful. I would like to get him back for a 75+ health assessment and a cognition test to check his memory and thinking.
Good idea. Thanks. Mr. Bird, I will see you in a week or so after you have your appointment with Sarah.
There's so much we can do for patients using our nursing knowledge, skills, and experience. Being alert to changes in memory, thinking, or behaviours is an opportunity to identify possible dementia and provide patients with the right care and support to live well. How are you getting home, Mr. Bird?
I think my daughter is coming to pick me up.
I can talk to her about what we've discussed with the doctor if you like. And I've written down the details for your next appointment. Let's ask your daughter if she can come with you.
Thank you.
General practice nurses are uniquely placed to notice changes that may indicate dementia, act early, and make a difference.
And work out how I move forward. So that little animation is just sort of a little snapshot, and there's something Dimity, a couple of others, myself put together based on all these conversations I'd had with nurses about what their thoughts were about what they wanted to know and how they can put it into their practice. And it's just that little thing about as a nurse, I can say that, as a nurse, I think we are just so exceptionally skilled and have the right sort of ethics of care and approach to care, and people trust us, that we're in such a good position to know when something's off. I mean, we just have these spinning heads. I think we just know looking at someone and what's happening and how they're moving and how they're talking to us, that something just has changed. And then what we're trying to work out here is, if we've noticed that something off, then to try and pinpoint what is it that's changed exactly and why. And then once we know that, then we can start to problem solve. And I just think nurses are completely underutilised in primary care. And I think this is somewhere where really it suits our skill base.
So Caroline, I'll just make a comment on that last comment. Two things about that. I've seen that animation a number of times, but two things stood out for me. One was that Mr. Bird says, oh, it's just old age. And we so often just accept that. They think it's just old age. Oh, yeah, it probably is just old age. And, you know, then we move on because we're busy. And this nurse in this animation didn't just buy that. She had noticed a number of other things and she was putting it together as possible dementia. And it doesn't have to, you're not looking to make a diagnosis. You're just looking to raise awareness. And then the thing I really liked about the nurse was that she said to that doctor, I suggest a 75+ health assessment and a cognitive function test. And so the doctor is not going to say no to that, because that is, you know, a standard part of practice. And if the nurse had said, I'm worried about his memory or something, then the doctor might go, well, you know, that, you know, we're venturing into diagnosis here. But if the nurse says, let's do this, and then you can review it, that is so much a standard part of practice that I don't think too many of you would get pushback if you made that suggestion. The doctor would probably say, oh yeah, just go for it. I don't have to think about it until I get that report back. So yeah, so I just wanted to make those two comments.
Yeah, and I think we're going to talk a bit more about the 75+ and how we can use it. I was going to start talking about it now, but I thought when we do a case study later, it might fit better in there. One of the things too, Dimity, people asked me before when they've seen the videos, that difference between when we notice the changes, like with Mr. Bird, there's no scope for how fast those changes had occurred. So what are your thoughts on that? Like there's these subtle, slow changes, or if it had happened suddenly, it could actually be something quite different.
And in fact, Louise has put in the chat here that if it's a sudden onset like that, is it reasonable to suggest a blood test rather than the 75+?
And some people have watched this, and when I even tested it along with some friends, said, oh, but that was sudden, because I never gave a sense of this creeping up, which is what I meant. And so, yeah, Dimity, so okay, it's sudden.
So Louise, you're quite right.
Yeah.
Well done.
Yeah, so then you're most probably thinking more of a delirium picture and wanting to maybe do a wee test and dipstick, set of bloods, listen to his chest, get a different medical grounding as well. I meant it to come up more as she's been seeing him over time, and it's that he's usually so well groomed and that slow thing. But I don't mind it coming up the way it has, because it does, again, was it Louise? As she's thinking correctly. Now she's put another layer onto it. Hold on, what time frame has this happened in?
Yeah.
Like I saw him 2 weeks ago and he was fine. I see him now and look what's going on. And yeah, there's that time frame as well. That's another clue for you. Usually changes in a little, D dementia, cognitive changes that we're worried about, they are subtle and slow, and they just slowly accumulate over time. And often they'll be missed, and it will be later down the track. The family might say, now when I think about it, this was out of 2 years ago. But it's sort of a retrospect. People start noticing things are falling apart. And these sort of changes that are up here on this picture now, the sorts of things that you'd be looking at, which is what we were sort of talking about when we talked about sections of the brain and what they do. So, orientation and learning and judgment, speech, language. And then that one about depression and mood and withdrawal from activities. And that can be a mood thing, but also that sort of anxiety thing of not being sure what's going on and feeling embarrassed or worried. And depth perception. And we'll look at some of those and what they mean.
And Brooke has suggested a urine test. Yeah. So good.
I can't read the thing. So what have we got in there?
Well, Brooke said urine test.
Yeah.
And Louise, it's just Louise's comment that blood tests. So
Yeah.
it sounds like our audience is getting on top of all of this. It's really good.
Oh, and this is what's so good is having, just trying to gather some information together. And when we, Dimity, last time talked about when we actually go down that, or not us ourselves, but it's good to be aware of the diagnostic process, then bloods and all that are part of that diagnostic process anyway, regardless of time frames. But that first noticing clues and trying to think through what might be happening, slow and steady, more likely a dementia pathway, very fast, sudden things. And interestingly with delirium too, and I always have to remind myself of this, I don't know, Dimity, what you think, but often in my imagination, delirium is loud, hallucinations, yelling out, quite hyperactive. And you've got to remember there's what's it called? What's the other delirium called? Hypoactive delirium.
Yes.
Yeah, in which someone will just sit very quietly and not talk or do anything. And people will either walk, like especially in hospitals, they'll either walk past those people and think, great, they're no trouble, or that they're just feeling a bit down, whereas actually they have got a delirium, which is going to have the same impact on their brain of not recovering as well, for example, when they go home. So I don't know, Dimit, if you've had anything experience with that, but I've got to remind myself it presents both ways.
Well, they often get sent home from hospital in that state.
Yeah.
And whereas they don't, if they're more overtly behaviorally disturbed, they don't get sent home, but they may get sent home if they're that quiet, confused person. And then they don't look after themselves. And we all see people who've been discharged from hospital on Friday afternoon and they come in on Monday morning in a state of chaos with, not having eaten properly, no food in the house, not, and not sure what to do, and medications all over the place and all that. So, and of course, medications is another thing. You need to think of the dementia, delirium, drugs, meaning medications. Can sometimes give them that, and depression's another thing that can make them appear cognitively impaired.
Yeah, so it's not simple, but it is a matter of, and as I said, I think we're very good at it. All health practitioners are good at it. Nurses are good at it. So let's remember we've got a role here. Noticing something's changed, just noticing something's off. And then it's starting to dig down and try and work out what is happening there and what's causing it. And this is one of the things that we most probably don't do as well, is going down this cognitive pathway, which is why we're all here. So I've got another video here, and I think I love this little video, and it's just about people talking about when they first noticed, and these are all real people, and when they first noticed the changes and what they noticed and what they thought those changes meant. And I think it's interesting to hear their stories. So we'll just have a look at this.
I suspected for quite a long while, not taking as much responsibility, losing car keys, losing his wallet, losing his watch, getting lost when he was going out driving. All these little signs sort of started to add up in my own mind.
Well, it was when my husband Peter started to withdraw, sort of within himself. He started not wanting to talk to me, and he started to withdraw from the children and to his friends to a degree. He started getting very tired. He used to go to bed early, and I thought that was a way of avoiding me. I thought that there was a problem with their marriage rather than that there was something physically wrong with him.
I think it was day by day things that started to come undone to begin with. Little things like not being able to use the taps in the bathroom that we thought was a major plumbing problem turned out to be the fact that Mother couldn't regulate hot and cold. We'd gone to a little cottage in the middle of the rainforest to sort of just have a relaxing time, me thinking, well, Jamie's stressed. By then I'd given up work because I thought he's stressed and I was in a fairly stressful job, and it was just the two of us wasn't working. And so we played a game of Scrabble, which we'd always done things like played Scrabble on holidays. And it took 5 days to play one game of Scrabble.
and he was so determined he wasn't going to give in. And I just felt sicker and sicker as the days went by, and realised that he just couldn't think up words.
Then he had a problem at work where they felt that he wasn't performing his job properly. They referred him to a psychologist because they thought he was suffering from stress. And from there, he was referred to a doctor and just to a GP. But that's when I felt that there was possibly something more wrong than rather than just something that was an emotional problem or something caused by stress.
Then driving home, he suddenly said, I've got a problem and I can't remember things, and I feel terrible because I can't talk to you. I can't think of things to say. And I'm worried there's something wrong with me. So we talked about what it could be and whether it was a brain tumour or whatever. Or Alzheimer's. Alzheimer's seemed so unlikely because he was only 55.
And I think the preliminary signs, I probably missed a few of them. But the real cruncher came when Molly appeared to be having trouble with her eyes.
Well, I really didn't think I had a problem. I just thought it was because I perhaps was living alone and I wasn't able to relax. She was an instant no to any suggestion. If you said, would you like to come over for lunch? Oh, no. And then you'd have to sort of coax her into coming out. And there was no real reason why she wouldn't come, because she always used to like to go out previously.
We went and saw an eye doctor, and I'd known this guy previously. And he called me aside and he said, Jim, I think you should see a geriatrician. He said, I think Molly may have Alzheimer's disease. And I can remember that very clearly because I knew this guy reasonably well, and I was standing by the window in his little office and I looked out the window and I thought, bloody eye doctor, what would he know about it? He was dead right, of course.
He refused to have any tests done. He refused to go and seek advice because he said that if he spoke to any of his partners, then they would, you just couldn't be a doctor if you had a major problem. And especially if it did turn out to be Alzheimer's, then he wouldn't be able to work anymore. But then when you pointed out that he wouldn't be able to work if he did have Alzheimer's, that he shouldn't be working, that was another sort of problem that he just couldn't really quite face at that stage.
He was having difficulty with his memory. He would forget a lot of drugs. He was very clever about it because he made up a lot of prompts and reminder cards. So I don't know for how long he hit it very well because he was a very bright man. And often at partnership meetings also, he would forget events that had happened in the past.
You sense that something's not quite as it used to be. So, but at that stage, you don't have any label to put on it.
Let's move that forward. I think I quite like that video. I think it shows some of those subtleties. And I think it's also interesting that the first things people jump to is when it's something wrong with our relationship. A couple of people said brain tumour was up there as something, and we often hear that people think must have a brain tumour. The number of people, when I talk to them, people living with dementia and their families, is the first things that happen if there's changes at work is they get referred to the work psychologist or one of those programs and for stress. And of course, it doesn't help. And it often just becomes worse and disenfranchises people a little bit, but it does happen quite often. And also the one with optometry, I think that's interesting. I had a few people that have come back with the optometrist saying you need to follow something up. When they look behind the eyes, they see vascular changes. And I think, isn't that right? That's right, Dementia, isn't it? I'm not assuming.
Yeah, that's right.
When they look behind and see vascular changes, then that's a sign there's obviously something's happened vascular. Can't explain that very well, but I do hear it.
Yeah, and I had one whose dementia was affecting the visual cortex, which is at the back of the head. That's why I'm banging the back of my head. And the optometrist picked up that she couldn't see the top right-hand corner of her vision. It was missing. And he actually couldn't see any changes in the eye itself. So he referred her to an ophthalmologist thinking it may be dementia, and it was. Yeah.
So I think that's interesting because you sort of think, oh yeah, eye checks, you know, like your dental checks, your eye checks, your hearing checks, blah, blah, whatever, you know, gets drags on a bit. But it's one part of that health promotion is actually so important, particularly, you know, eye checks and all that, not just if you've got diabetes, because it is actually amazing what, you know, you visit to Specsavers or OPSM actually can pick up. And so they're worth it as part of your health promotion checks, you know, with your vaccinations, and have you had your eye check? Because now I think OPSM do it as well. They do that quick hearing check as well at the same time. And that's at least a good start when you're thinking about these risk factors. And maintaining sensory stuff's so important anyway, because if someone's not hearing properly and always asking for things to be repeated or not knowing what's going on, if it's actually, it might not be a cognitive change like we talked about last time. It might be a hearing problem or a wax buildup, or, you know, they need hearing aids or something like that. And then what everyone's perceived as a memory problem is actually then resolved. So our senses are really important. What we're going to look at now is, so we've sort of looked at what some of these early changes could be and what the risk factors are. But now what we want to look at a little bit more is, so if someone has got a cognitive change, how might that show up for us to notice? So how might that impact on their individual function? And when you think about it, and I always find this a little bit difficult to explain, but a cognitive change first presents as a functional change. It's the functional change that we notice. So, for example, we might notice that someone's missing appointments or muddling up their medications. That's what we notice is the change. And then what we do is we think, okay, is it because there's something then wrong with their memory or thinking or whatever? So it's, yeah, and so that's why we talk about function here. And also because as nurses, we don't look at diagnoses and drugs and that. We look at how someone is functioning. So that's sort of why we're going to explore it in this way. Before we do that, because part of exploring the impact isn't just what we're seeing, it's also about asking questions. And often, and one of the things why we look at function too is going to make it easier for you. But one of the things too is how health practitioners have said to us, oh, we don't know how to ask about cognition. Now, doctors and nurses, allied health, everyone has this challenge. And I think it's often because we're hoping with the way we present our information, it's trying to present it in a way that it makes it more everyday for us to be able to approach it and not feel so confronted by it ourselves, and not to our patients to feel confronted by it. Because we want to ask about people's function. We want to address it in a positive way. We want to emphasize the idea that we're here to help you live well. We're not going to come out and say to someone, well, what's your memory like, you know, and make it sound like it's a problem, or that we're going to start being judgmental, or there's a stigma or something like that. And people still think if we ask a question, they've got to be fairly brutal about it. And we don't. So we'll just quickly cover some of that. So I've just got a couple of points here. Then I was wanting to ask Dimity, because as GPs, they often will be having this conversation. But I think the way I sort of summarize it as is we're going to use a non-threatening approach. Now, one thing I've got wrong in that Mr. Bird video is, and it bugs me every time I see it, and I can't change it now, but it's a good one to see if people pick it up, and they do sometimes. Today, people picked up a delirium possibility, but I call it a cognitive test. One thing to avoid is do not call it a cognitive test. Get rid of the word test. It's a cognitive assessment if you're going to describe anything, or a cognitive tool, because you're going to explain to people why you're doing this and make it non-threatening. And the first thing to make it threatening is to call it a test. So my mistake. Slipped into a bad habit there, bad routine habit. But I often will frame things, put things into context as a problem that other people might. So I might ask someone about their baking or preparing meals and say to someone, oh, you used to bake all the time, and I notice you're saying you're not really cooking for yourself anymore. That happens with a lot of people because, you know, they might find they can't follow a recipe properly anymore or something. Is that sort of what's happening with you, or what's happening with you, or is it similar? So I try and sort of frame it as a common concern, so I'm not singling them out or they're not in trouble or something. That makes sense. So it might be like, oh yeah, some people have stopped going to the community drinks night because they were worried they were forgetting people's names. Do you find that's what is happening to you, or does that sound familiar to you? And just try and introduce it that way, and then you clarify meaning and probe. And when I said before about keeping it positive, it's sort of that statement like there at the bottom. I try and constantly reaffirm with the person and reassure them that the reason we're talking about all this is to try and stop them, because often people get quite paranoid and hesitant and withdraw and get a bit heightened, like there's nothing wrong with me. Why are you asking me these questions about my memory? Or why is such and such turned up with me today? Are they checking up on me or something like that? I keep it that idea that, look, it's really great that we're talking about this, because if we can figure out what's going on, what's not quite right, then we can do something. And then we can get you to be able to do the things that are important to you. And so constantly trying to reinforce that what we're trying to do is positive. And part of you being here today and us having these conversations, and as we progress through the slides, is ways that we can then make it positive. How can we talk about it in a positive way? So, Dimity, I was just curious, because from doctors, so we hear a lot with GPs that one of their reluctance to go down this can of worms is, how do we speak about it?
Yeah. And
and any advice to us?
I think I mentioned to you that I told my own practice nurse that we were running this webinar, Caroline, and she said, well, tell them that the one thing that keeps people away from having their 75 plus health assessment is the cognitive function test.
Good test.
And so that's exactly what you've just said.
Yeah.
And she said, we've got quite a long corridor to get down to the treatment room. And then one of the doctors likes her to do a cardiograph, an ECG with every 75 plus health assessment. So she has a bit of a chance to chat. And she said, I always start asking them the questions. I go, I bet you're worried about that test. And she said, and they go, oh, yeah, I know, I almost didn't come. And she said, well, let's get started. Now, you know what the date is today. What day are we on? And by the time they've got down that corridor and she's done the cardiograph, most of the cognitive test is done. And she can say, there's only a couple of bits left now. Let's do that copying the diagram thing and the clock drawing. So that's one thing. So for me, I agree. For me, raising the question, which is what you asked me, is it is challenging, and people often do say my memory's not what it was, and I do tend to pick up on it in a way that I didn't when I was a younger GP, but now I'm more aware of dementia, and I say, do you think it's sort of impinging on your life a bit more, that memory problem? And they go, oh yeah, well, yeah, it is getting worse. I'm worried. And I say, well, it could be a lot of things. Why don't we look into it, the hearing and so on, and maybe get the nurse to do the 75 plus health assessment, give you a thorough check over your whole system, your body, your blood pressure and everything. Maybe there's something that we can fix, or it could be your medications. And we'll do one of those cognitive tests. I do say the word test.
It's so hard. It's so hard not to do.
Not to.
I know.
Yeah. And but that's just one of the things. We might be able to fix it. And if we can't, it's not the end of the world. And I always say to people, if who are perhaps along the line of going to the memory clinic now because really it's a problem, and I do say to them, you're still a person. Even if you get a diagnosis of dementia, you are still a person, and you've still got a right to say you want milk in your tea or not. You've still got a right to boss your kids around. They may not listen, but they never have they? And we make a little bit of a joke about it, and I'll still see you and I'll still talk to you. So, you don't suddenly fall off a cliff just because you've got that diagnosis. And that is really the kind of thing that people worry about, that they'll become a non-person in some way. And so they need a bit of reassurance that I'm not going to ignore them and only talk to their family carer in future or something like that.
And I think it used to be quite brutal in a way in the old days, or even still fairly recently, that so many people who are advocates now, they live with dementia themselves and they're advocates in this space. Were told even when they got their diagnosis, it was very much that approach. Well, you've got dementia, go home, sort out your things.
Your affairs, put your affairs in order.
Put your affairs in order. If they were younger, quit their job, etc. And it was, but nothing was built on, well, what can you do now? It was just that everything had ended. And I think community and that stigma attached and how we might view what people with dementia, who they are, still really influences that. And I think it's up to us one by one and influencing those we work with and in our own practice to try and reframe it. And like what you were saying is keeping it also holistic. You're not targeting just the brain part. You're also saying, well, let's check your heart. Let's check this. Let's check that. I mean, it's all part of one package of you. And whatever's happened to you now, we'll work with that. And we will work with you to achieve what it is you want to achieve.
And Brooke has made a comment, which I think is very true, that there's so much fear around the idea of your body remaining strong, but your mind is gone.
I know. Yeah.
And is sort of a nasty thought, isn't it?
I think it is. And look, no matter how much I try and keep trying to frame it as positive to sort of overcompensate, I think sometimes I try to do that. It's not a nice disease. It's a horrible disease. There is so much about how we think and what that means to us as a person and that whole sense of autonomy and all that. And there are those sorts of losses, whether you like it or not, with a brain disease and including dementia. And so often we do see people that are so remarkably physically well. I don't know if you see that in your practice, Dimity, but I do see people at home is they're really physically quite fit. And the poor carer is the one with the physical frailties. And we joke about it like, well, it's good you're a team because you've got one that's thinking and one that can actually then hopefully still follow the instructions and do the doing. But it is, I don't know, is it common or is it just what we see or remember that people are often physically still quite well?
Yeah, no, I think it's not uncommon. Even people
I
in
don't
nursing
understand
homes.
how when they've got, if the stats are people living with dementia have 4+ comorbidities and are more poorly managed, how do they still say so well?
Well,
I don't know.
Ashish has just said it's very common. Ashish is one of our listeners.
Yeah, it is.
Yeah, I think maybe what I think is they don't have as many worries.
Maybe it's not something they dwell on, they just get on and do it. Maybe
because they've forgotten about their financial affairs and things, so they're just living in the moment all the time, and that's probably a healthier way to be in some ways.
Yeah, I don't know, Brooke, it's something that someone needs to do a research project on. I think any budding PhD students out there. Yeah. But I think it's really interesting, and it is often the case. And I think sometimes when there's behavioural changes, that in itself is what causes the problems, is the person is still quite strong and tends to get stronger. And often that's where as fear comes into that too, particularly in residential aged care, I think, because people are still physically quite fit and they're physically become threatening.
And it's very hard if it's a big male.
Yeah.
And with a small wife trying to look after him.
Yeah.
Yeah.
So no, it's definitely an issue and it's something we have all noticed. Anyway, so going on to talking about function, and this is what I was saying are the things that we sort of notice, and that's when we notice these things, this is when we start asking questions to find out what's going on. And then to start finding out, for example, who shall I pick on, what picture? I don't want to double up, so okay, let's say going out, and so we're an avid gardener, so they're always going out and doing the gardening and things like that, and you've noticed that they've stopped gardening. I mean, you're not then just because it's today going to suddenly think, oh, something's wrong with their cognition. I mean, it could be pain, or it could be that they're just recovering from COVID, or they haven't slept properly, they've got insomnia. So I mean, there could be a different sort of medical problem. But my argument is we don't discount that it's a cognitive cause. And if it is a cognitive cause, say it's a pain cause, then there'd be a certain strategies we'd come in, like we'd look at, well, what makes the pain worse, what makes it better, etc. Analgesia, pain management, non-pharmacological pain management. But if it's a cognitive cause, then those strategies aren't going to be effective. And so that's really what I'm going to try and get at in this next little section. So I've got a couple of little sort of scenarios that, so you notice that there's been a change in social activities, and you remember we talked about before, social connections are actually really important. And we want people to be maintaining those. And in dementia, it's doubly so, because people with dementia have really high risk of social isolation, as do their carers. And part of that is them themselves not wanting to go out, or the carer not wanting to go out with them because they might do something embarrassing or whatever, or it's just too difficult because they might be wandering off, or they lose them, and it just becomes too much. Or it also is that often people will comment that our friends have dropped off, they stopped coming by, and it might even be family members because they just don't know what to do in this situation or what to say, and they don't feel comfortable. So it is a real risk with people with dementia, so it's something to keep an eye on. But in this example, Max, I've got Max here. He's stopped doing activities that he previously enjoyed. So, for example, I've said bowls here, and you ask him, "Oh, that's why have you stopped? You know, you used to really enjoy it. You were the captain of the team for decades." And so you ask him to tell you more, and he just says, "Oh, it's too hard to get there now." And so your strategy is, okay, let's get some transport for you. We know you stopped driving and the bus routes change, so let's organise some taxi vouchers, because we can get them in primary care. Of course we can. No, we'll work out something, half-price taxi card at the very least, and maybe some community transport, one of the volunteer transports to get you there. Problem solved. So you see Max for a review, and he hasn't used the transport. And so you're like, well, that's a bit frustrating. You told me you couldn't get there, you know, and it was important to you to get there. So, but maybe there was a different reason that he wasn't so keen on disclosing, but with a bit more probing, you might be able to find out that the reason he is actually not going to bowls is because he's forgetting people's names and feels embarrassed about it. Or he's misnaming misnaming objects he should know really well, such as the jack and the bias. So if he's been a captain of a bowling club and all this sort of thing, then he should know what a jack and a bias is. And that's aphasia, for those who like to know. And if you know that sort of information, that's the actual problem, you're going to have different strategies. So taxi vouchers and community transport really aren't going to be helpful for those problems. But a friend or a buddy for reassurance and support might be. And so that's when you might then start asking Max, well, is there someone you trust at the club? Is there someone you're willing to talk to and say that you've got these worries or concerns? And maybe they could pick you up and you could go with them, and they can just be, on your back shoulder for a while, reminding or prompting you, or just trying to make the situation a little bit easier so you feel a bit more confident. And I've had this work effectively with a lady recently who lives in one of the retirement villages where they have the Friday night drinks. She's got someone now to walk past her unit and pick her up and take her. And she hasn't disclosed a lot to this lady. Doesn't need to. Just needs that idea that, because they know, people know as well. And they want you, generally speaking, if you've been part of these groups for a long time, people are very generous. They want the people there and they'll be kind. And that's what I've generally found. So try and find a friend or a buddy if it's like this. Say you've noticed someone's got a change in their grooming or personal care. I mean, is it just that they can't be bothered anymore? Is it a depression, or is it pain? They've just been unwell, etc. But maybe it's become too complex due to cognitive changes, and that's your different strategies. And so what I mean by too complex is what we're saying before about apraxia, or being able to manipulate things with your fingers. So can someone, say you've always had someone come in and they've always worn a tie. Ties are quite difficult to do. And if someone's stopped wearing a tie, that's something worth noting and then trying to add to and see if there's any other things that are off. Someone might suddenly have their cuffs always unbuttoned, or they're not wearing the fancy brooch on her jacket that she's always had because she can't clasp it anymore. And they're things that that's cognitive change. And so you're going to want to look at different strategies if that's the reason. So I've got some of the other cognitive changes here. So that guy in the bottom, I was trying to get away around the idea of the buttons. But also clutter can make things really complex, and that could be grooming, showering. I mean, it can be also preparing meals or whatever. That's a very cluttered surface there. But the idea is if people have got a cognitive change, that diagram up in the top right corner is called the Popple-Writer test. If people have got a perception change, then they can't see things that are overlapped. So they wouldn't be able to see, say, the fork in that picture because they can't make up the whole picture. They'd see the little bit sticking out the end, but the bit that's overlapped, they wouldn't be able to distinguish that. We just see it, but people with certain brain changes will not see that. And that's the sort of person you'll hear say, oh, yes, be stereotypical. The wife says, he's always asking me where his glasses are, and they're right there under his nose. And what you'll most probably find is they're half under the newspaper. So he won't see the glasses. He only sees this half, but can't make them up into a set of glasses in his brain. So it's about simplifying tasks. Also, that bottom one in that bathroom I've got there, again, a perceptual change with the brain. You hear someone's resistive. I don't like that word, but everyone uses it. Resistive to having showers. They won't have a shower. Doesn't matter how much I tell them, they will not get in the shower and wash. And if it's a depth perception problem and they've got dark bath mats, then it can be perceived as a hole. So they're having to negotiate this big hole to get in the shower. And so they're not going to do it because they're afraid, or someone's trying to push them into the hole. So it's just worth thinking that there can be all these other sort of reasons, because our brains are pretty amazing. And if it's not working properly, you can get some pretty weird things happening. And so some of the things are to help someone, say, with the example I originally was around grooming, is to simplify the environment, have clothes that are easy to get on and off. So not tracksuit pants and things, even though you can get some quite nice elasticated things, but we want to maintain dignity as well. But Velcro straps or things like that, or bigger buttons might work for someone. Sometimes you can even provide just a couple of choices of clothing, so it's less overwhelming. So you could, and these are things you could just let the carer know. So if they come to you and they're really stressed and anxious and like, he's not doing this or she's not doing that, or it's really difficult, just sort of say, well, look, let's just calm, take the heat out of at home so it's nicer for everyone. And have you thought of, just simplifying things? Or sometimes I used to have a lady who had a neat trick of the husband dressed himself, and it's good because you want to maintain the independence, and she'd stack the clothes on the bed in the order he had to put them on. So he put his socks on first, so the socks were on the top, and then so she put them in order. And that also helped, because some people will put clothes on, like you'll find some people put a bra over the top of the singlet or over the top of the shirt, or things the wrong way around, but she found that really helped. And providing a couple of steps at a time, or setting items out so they can be clearly seen. Some of those things can work. And some services might be able to support, like you might district nursing or some personal care services. Occupational therapy is really useful because they can go in and do task simplification, and there are aids that you can get that can help some people. Environmental changes. Dementia Australia actually don't have the help sheets up easily accessible anymore, unfortunately, to change that. But there is some good information there you could lead people to about how to change the environment. And that just might be useful resources for people you work with. But we don't have to become experts in this. It's just nice to know that, just to start us thinking a little bit differently, that, hold on, if it's not pain that he can't do this, so it's not because he's unwell, if it's because part of his brain's not doing things the same way, then there's different things to look at. And you can just direct people to, say, Dementia Australia, and they'll help with that too. I just think it's fascinating.
And it can be very practical. Like that lady I told you about who couldn't see the top right-hand corner of her vision. She used to wear lace-up shoes, and she used to walk from home to the practice. And I noticed one day that her shoes were not laced up. They were, and I said to her, you better just do up your shoes before you go, because you could trip. And she actually couldn't do it. And that may have been because she couldn't see them well, because she was losing a bit of her vision,
Mhm.
but it may also have been that the dementia was made it too
Yeah,
complicated
it'd
for her
be
to
a
do
lot
a
of
shoes up.
manipulation. Because remember, how
So-
long does it take to teach your kids to do up shoelaces?
Yeah,
You've
exactly.
got to try and, yeah, it's quite
So I
challenging.
said to her, how about getting some of those shoes with a Velcro across? You know, you can get quite nice looking ones. Doesn't have to, you know, show itself to be weird.
Mm.
And then you don't have to worry about doing laces.
Mm.
So little suggestions like
Yeah.
that. I had to remind her several times before.
But
It
that's
happened.
a good one, I think.
Yeah.
Shoes and shoelaces. That's another one like the tie. They're ones you pick up quite quickly.
Yeah.
We better move on because I didn't realise the time. I'll just quickly do continence because I think continence is important because this is often the trigger for people to go into residential aged care. It's often the tipping point. But I think we've got to remember too, if we hear people not getting to the toilet on time or having accidents or using the pot plant or whatever, and we do hear these stories, it may not be a continence problem. It may actually be that the person might find the toilet okay, but they can't because of this problem with dexterity and working out how to coordinate. They might not actually be able to undo the clothing fasteners quick enough, so end up with wet pants or, you know, wet clothes. Or if they've got changes in depth perception, they might not work out. Often if bathrooms are white and things are in bowls, so you've got a toilet bowl, a vanity bowl and a bath bowl, then people can mistake the bowl. And also it can be that not getting there on time is because they can't remember the way there. And so, for example, the wayfinding problem, often I find what's useful is if people even just stick arrows and then a picture of a toilet or a toilet on it, and then you've got some arrows or even signs saying this, you know, toilet, this is that room, bedroom, kitchen, glasses, mugs. You know, sometimes that's enough for people to be able to orientate themselves. And that way you're helping them maintain their independence. And if it's a continence thing, you're potentially reducing the chance of them going to residential care earlier than they need to. I just always think that one's worth mentioning. I won't do appetite's the same as the others. We just want to have a quick look at a case study, and I'm going to give Dimity a go now. She can read this. I'll breathe.
Okay.
And we've got about there's 23 minutes left, Dimity, so we got a bit of time.
All right.
Any questions as we go, please throw them in. Dimity can read them. I can't read them off this screen.
Yeah, I can read them because I've got you. I can see the chat and the Q&A. So this is just this is actually based on one of my patients, Jenny, 82, lives alone, diabetes and cognitive impairment. And she's taking a diabetes tablet twice a day. And she started missing appointments. And so she's supposed to come every 3 months with diabetes alone. But I often see people in that age group much more often than that, every 6 weeks, perhaps. She'd missed her previous 2 appointments. And so I hadn't seen her for a while. And I weighed her. I noticed that she looked a bit as though she'd lost weight. And she has, in fact, lost 5 kilograms. And I decided that she probably needs a care plan. So I did the bloods that would be necessary on a care plan so there's a couple of the bloods there, the hemoglobin A1C, which is a diabetes measure, which had been done 6 months ago, and it had gone up as well. So she wasn't looking after her diabetes very well. And I thought, I think she needs to see the GP practice nurse and perhaps, and what I like to do actually is talk to the nurse about the patient and go, this is what's happening. I've done these bloods. What do you think? How would you like to approach this care plan? So if I handed that over to you, Caroline, and I might say, I think she's not eating properly and maybe she needs Meals on Wheels or something. Can you organise that? So how would you? I know what Caroline's going to say. She says, go away from here, doctor.
So I used to sort of think, yeah, we do a care plan, but a lot of nurses suggest, and I think it is better if we, depending on what has been done and what we do, is a health assessment is actually a really good starting point because we can get a quick snapshot overview and it does look at function. And so I think what would you do in your nurse role? Perhaps if in this case is, look at doing a 75 plus health assessment first, if it's appropriate. She's 82. And then we can get a better track of, okay, what checks has she had done? Does she need eye checks? And, we've got a weight there, some bloods and all that sort of thing. And then we can start looking, okay, has there been some functional changes to add to this picture? Like, okay, so maybe she isn't eating so well. Why might that be? And the Tidy Time Meals on Wheels is going to be useful. Is if she's not eating well because she can't use the microwave anymore, or she's not remembering to eat, then a delivery of Meals on Wheels might not be as helpful. You must be just going to end up filling up the fridge and freezer and God knows what else. But there might be other strategies, and if it is, say, eating, you could look at a service to come in which would help with meal preparation and work with her to prepare meals, or there might be another service that comes in and could do a prompt, or it might be that a sticky note up on the fridge is enough to prompt her to have something to eat. I don't know. We don't know what the problem is. But this is what I was talking about with those previous little slides about making the assumption someone's not eating well, they're losing weight. Oh, we'll organise Meals on Wheels. If we don't actually know why it's happening, it's difficult to know what the actual solution will be.
And I'm getting some comments here, Caroline.
Yep.
Brooke says ACAT assessment, obviously.
Yep.
Not for Victoria, which is ACAS. Webster packs,
yep,
medications, and family input.
Yeah, definitely.
And I think that's a really good one.
Yeah, I think I'll go the family input first, because that's I was going to say the simplest one, but it's actually not, because you've got to often there at work. But that's actually a really interesting one, because one of the things to notice, when we're saying we're picking up change and noticing change, if a family member suddenly lobs up to an appointment with someone and they don't normally, that's a huge red flag, because the family is concerned, because they've suddenly come to the doctor with this person. The person doesn't know why. They're a bit suspicious, and they want to know, and that's a red flag that something's not right at home, and you want to know what it is. But the ACAS assessment, was it, and the Webster packs. So going, say, with Webster packs. Now, we don't know what was on the next slide. Did we say we did have an extra bit? I'll just put that up now that you can. Yeah, okay. So we'll just go this and I'll go back to those. So we noticed that.
Can I interrupt with another question or comment? This is from Annalise. She says there's such a long wait.
And Webster's, yep.
There's a long wait for obviously where she is, and also where I am, there's a very long wait for the My Aged Care assessment. And what would you do in the interim?
Yep.
How can you, because I'm beginning to be worried about this lady's sort of safety, ability to look after herself and stuff.
Okay, I'm just writing it down to try and get these in order. Any other comments, whack them in, because we'll try and.
All right. There aren't any at the moment.
Yeah.
I'll keep an eye on.
So I've written those down, but just because we'll keep bringing it back to someone for context. So we've got, her MMSE was 28 a couple of years ago. So if we in the health assessment, the MMSE would be useful to do again for see what change there is. She's managed.
It's 22 now.
Now 22. All right then. They say, and the nebula, whatever they, what is it? A drop of 4 points in a year is significant. Yeah. But of course, that's put it in context. But if you ever want to know that numbers wise, it's a drop of 4 in a year. And 24 is when you're considered as potentially having a dementia, aren't you?
More
cut off.
23, 24 or 24, 25. Yeah.
But again, that's contextual. So we know that Cheryl's taken the day off to come. So we just said that was a red flag. She doesn't think Jenny's eating well and forgetting her medications. She's also socially isolated. She stopped going for her walk and coffee. And Cheryl's busy. She's got a young family and working, and so she can't keep an eye on her too often. This would be an absolute classic case of thinking, right, we need a My Aged Care input here, and we want an ACAS assessment. So if I start with that one, yes, it is challenging. I sometimes get really depressed by a healthcare system and sort of try to disengage a bit. And then I remind myself that, look, we can only do the best we can. And the right thing for us to do is still to make that referral. And I talk about it with the patients and just say, look, I know this is going to take a long time, but let's at least start it. So get the referral in.
And so what I'll just add in
Yep.
what I do through the primary health network, and we've got primary health network people here, is I can get social work support through the primary health network, and they can mobilise an interim.
I've got some stuff, interim stuff too. Yeah. So do the My Aged Care, get that one out the way. So you've got that in there, and they're in the wait. Because it can be months before someone actually gets assessed. And I've actually doing some work with ACAS at the moment. It's quite interesting. I do feel like I've gone over to the dark side, mind you, but it is interesting from that side because I actually get to see how long the waits are. And very often I'm seeing people who've had an urgent referral back in April because they've just come out of hospital and need the help. And I'm seeing them now and they no longer need it. And I'm like, oh my God. But yeah, it is hard. But at least that one's in. Then the interim is finding other resources. And a lot of that is up to each of us in our regions to find out what's local. Okay. So I would be checking your PHN health pathways. I'm just going to flip ahead for a second to the one that's useful. Now you get a copy of this. So when you go into it, fast forward and get to this one, or take a photo of this slide now. I think finding your local formal and informal networks is what's most important. The resources prior to this, like your Dementia Australia and all that. Dementia Australia and Carer Gateway are a good one-stop shop for information, education type stuff, support groups and everything. And it's really, that's important. Your primary health networks have health pathways, and that will give you a lot of local sources. Service Finder will also find you local people. Now, community connectors, local councils, or again, Google them. And I think some of the PHNs have who their community connectors are. They're there to help people navigate the aged care system, okay? And care finders are for people who don't have any carers. So community connectors help anyone. And then there's care finders that are in My Aged Care, so people who don't have helpers. And then keep an eye out. You know, when you go to the library or at the school, notice boards, or supermarkets still sometimes have notice boards, local papers, local neighbourhood houses, community health centres and libraries will also, so if you things like volunteers or visiting groups or other people and talking to your patients, sometimes I find out resources through the patients. There can be some of your interim stuff. I know it's not quite what you're asking, but they can be some of it. Now, going back to interim, ACAS, it's so hard to explain, and we'll run out of time, but if this is what you want to know, this is what I'll tell you. What have we got? Okay.
They're giving you thumbs up.
All right, this is what I'll tell you then. I'll focus on this rather than, and I'll go back to Webster Packs because that ties up the rest. There's two, they're getting tied into one. There's a big change at the moment, you know, because they're talking about the aged care reform stuff is actually happening now and coming into play. There's home care packages, which a lot of people, I think when you refer to My Aged Care, you're referring for home care packages, okay? And that's got to wait with it. But in addition to home care packages, there's this thing called CHISP services, and that stands for Commonwealth Home Support Program, okay? Now, that's different. That means you get approvals for a whole lot of services that each have an individual code. And so interim, while you're waiting for the package, you can access individual services, okay? And you pay a gap. So you can get them a lot quicker. Now, you still got to wait, but you don't tend to wait as long for that assessment because it's not the big assessment, which is ACAS. It's actually what they call RAS. But refer to My Aged Care, because My Aged Care then filter out which assessment people get, and then hopefully you can get it. And then while you're still waiting for that, check what's in your local area, okay? And just get started. If all you can do And remember, we're working in a team with the patient and the family. I always say we're working as a team. And most probably can't solve this for you. I'm as frustrated as you are that we can't get these services in, because I know you need them and it'll make life a lot easier. But I'll get this bit into place, and then let's see if we can simplify some other things or work around some other things in the meantime. Some of that interim stuff can also be some of those strategies I talked about earlier to make life easier, such as getting rid of a lot of clutter, providing small steps, simple food, things like that, you know, not getting rid of the black bath mat. You know, there could be a whole lot of other things we could be doing and fiddling with in between that can make life easier. And that's the best answer I've got as far as an approach goes, because we can't just get services to start. Half the time too, you get through it and you get approved for the service and no one's providing it.
So our PHN where I am, I'm in Sydney though, they actually provide, if you're trying to get one of those CHISP things, they send you a whole list of providers and you have to pick them.
Yep.
Our PHN actually will provide someone to come and do a home visit and sit down with you and help you work that out, because it's
so they might have
complicated.
They might have the tender them for a community connector.
Maybe
our community connector in Ballarat sits in council. So City of Ballarat Active Ageing employs our community connector. So you'll find them sitting in different ages, locations, but I know ours sits with our local government council. But that could be something you could find out most probably through your primary health network, or Google it. See if you can find it.
And it might be in Health Pathways. Melissa might be able to.
Yeah, it might be
show
in
us the Health Pathways.
Your Health Pathways here who we're with today are pretty good. They've got some good information in their Health Pathway. So there is information, and then I just start keeping a little resource of my local stuff, because remember, it changes all the time too. It's not there to be easy for us. I just wanted to go back then to Webster packs. So when I'm just going to go back quickly to, oh, that's annoying. I lost everything.
It might be telling you something.
we're just going to worry about sharing for a second. I'll just start there. With, say, that case study, and we said, right, we'll do a health assessment. We found out some issues. One of the things was, say, maybe not taking her medications properly. And there was that comment brought up about a Webster pack. My attitude to that's the same as with Dimity when we first started doing these case studies, was the Meals on Wheels. I always say, and we know this, it's logical when we actually think about it, is go with least intervention first. So we want to, if our goal is to maintain independence as much as possible and quality of life, and so much of the meaning of our life is around what we can do for ourselves and achieve for ourselves, then we want to be trying to come in least intervention first. I've had doctors, not Dimity, but I have worked with doctors. If someone's not taking their medications properly, they jump to a locked box, you know, things like that. And some people might want a Webster pack. That's great. It's their choice, go with it. You know, they're happy to pay the fee and all that. But it may be that if someone's muddling up their medications, to me, the first thing to look at was, I'd like the doctor to look at or get a home medication review and check, can we simplify the medications? If, for example, someone's having 3 a day and it could be 1 dose a day, then let's get the 1 dose a day. If we get everything in the morning, let's get everything in the morning. And if we get half of everything and all in the morning, that's even better. So I'd start there. Then I would move, given, of course, I'm talking about just a person that I might know that won't work with, but that's where I'd start. Then I would, so simplify what they're doing. Then I'd ask them, is there something you do every morning? And it might be make a cup of tea. And then what I'd do then is I'd say, right, would putting a note next to the kettle help to remind you to take the medications? Or can you put your medications there? Then you might go to, well, what if you put them in a dose set box? Would that help? And you can sort of start problem solving, least intervention first, them having the most control. And then I'd move to a Webster. Same with the meals, least intervention first. Are there things we can do to support them doing it? And then I'd move ahead towards other people completely doing it. So that's just where I'd sit, that comment. I'm not sure what the Webster Pack was about, except about medications management, but that's my approach.
So, and just building on that, I
Yep.
often say to people, well, at the moment you're managing not too badly. Maybe we can make a few tweaks. Later, you might need a bit of extra support.
Yeah.
And people will say to me, oh, I'm going to have to give up my license. I go, well, no, hang on.
Don't bring up driving
immediately. But eventually you will, if you've got dementia. But let's cross that bridge when we come to it. At the moment, you don't need to. So, and just keep mentioning it, you know, and gradually they'll get used to the idea.
Yeah, and it's true. And that's about that constant conversation and trying to frame it positively. And, you know, we all have to give up driving one day, for example. Often there's a lot of element of safety and risk involved, even with medications. So sometimes it may be a different approach. So if someone's insulin and they're muddling insulin up, you might be jumping.
Yeah.
You might want to jump further, taking it out of their control than you would, you know, whatever else they're taking. Again, sometimes you can change the way the doses are done or how it's administered. And often it's the carers that get really anxious. Oh, they're going to be making a mistake, or they're not getting this right, and they'll be trying to wrest complete control. Because remember, they're in a very stressful situation. So sometimes it can be talking to them, because there's some things in life you can make a little mistake and it's fine. It really doesn't matter. You know, if someone insists on always doing the dishes and puts things in the wrong cupboards, so maybe that's okay. You know, maybe that's a battle you just go with. Whereas some people get really upped up. They don't put them in the right cupboards. And, you know, you most people met people like this. And I had someone who constantly wanted to do the dishes and they were breaking things. And so we worked out, well, why don't you just go to Kmart and get those melamine ones that don't break, just stack them up. And if they want to wash them multiple times a day, it just doesn't matter, you know. And I think it's just thinking about it maybe sometimes differently. I don't know. We've gone completely.
Caroline, I think we have to pass back to Melissa.
I know. So anyway, sorry. Hopefully that was still useful.
That was wonderful. Thank you, Caroline.
Sorry, Melissa. I forgot that we have you at the end. Sorry. Your health pathways, you have them up there and they're good ones. So
yeah.
I was just going to mention
we can't hear you properly.
Wait, is that better?
Yes.
Yay.
Thank you. Thanks so much for that, Caroline and Dimini. I just wanted to touch on the conversation around PHN resources. I think there's different resources available in different PHN areas, so it's probably best to approach your local PHN just to see what's available. I believe the Care Finder programs are commissioned nationally, but they're to local organisations within your area. In terms of health pathways, we do really try to map all of the local support services. So for that sort of interim point of care, we try and do at least as many local community support services that are available and wrap around care that you might be able to get your patient in touch with. I do also just want to flag that we have resources that have been developed by both COORDINARE and Capital Health Network, and these are, again, just mapping the local services that are available in the regions, and so they're for both patients and for carers.
Yeah, and these are good ones. So not all the PHNs have this level, Melissa, so it's really nice to see. And I'll be getting onto your site. Yeah.
Wonderful. All right, are there any quick questions before we finish? Let's see.
There's some clapping hands.
No, thank you. I hope she got something out of it. It's really just about just going in and thinking about things a little bit differently, being a bit creative.
And I think you're a great audience. Very interesting.
Yeah, no, thank you.
Good.
And thanks for the questions. They're really good. And yes, it is a bit frustrating accessing services, but as long as just start, that's all we can do. So,
okay. Thanks, Melissa.
Thank you so
Great.
much.
Thanks. No, thank you.
Okay. And I've sent you a link, Caroline.
Oh, cool. Thank you. Thanks, everyone. Bye. Thanks, Mel.